Fine, very good. Yeah, hello again. So thanks for having me again, us today. Today I'm here with Dr. Fischer from our department. And yeah, so this is our first case here. It's a patient with critical limb ischemia. Maybe I can have the slides to show you. So Sven Browning was supposed to be here. He's stuck in a traffic jam, so Dr. Fischer will replace him here. 67-year-old male patient, CLI left, so with Rutherford 5, some 4-foot gangrene and ulcerations for quite some months actually. ABI left 0.5. He already had an iliofemoral bypass quite some years ago and a failed recanalization attempt on the left side elsewhere. COPD, so this is the patient history. Next slide shows you, next please, the risk factors: arterial hypertension, hyperlipidemia. He's not a diabetes patient, but a former heavy smoker. And here you can see the angiography. It's actually a relatively long stenotic segment, proximal and mid portion, and then comes a relatively short total occlusion, and then you can see here the main artery distal is the posterior tibial artery going out. So the wire was stuck here in the total occlusion of the distal total occlusion, and the patient was sent here. And next shows you our intention how to treat. Next slide, please, to go left antegrade. Actually, we are now in crossover to try a second attempt from antegrade. And if this doesn't work, maybe come from retrograde. You can see here the proximal antitibial artery, which we have now already punctured. Yeah, let's switch to the angio screen, and I'm going to show you what we have done already. So this is left antegrade. You can see here we are strong confirmal here after surgery. Then the profunda origin is nice. Actually there the SFA is not diseased, and a second branch, however, gets off right where the disease starts. Altogether, it's not too calcified here in this portion. And then further down, and see here that even the mid portion, it appears to be relatively non-stenoted, not stenosed, and then tight stenosis again, and then there is this relatively short occlusion here. Artery goes directly into collaterals. Also here it's not too calcified. A little bit of calcium here. Yeah, we thought this case could be actually a good one to maybe do a combination of drug-coated balloons and potentially a stent in that total occlusion, where we expect, of course, more dissection, residual stenosis. But proximal, we thought we can take the Ranger drug-coated balloon and maybe distal here, combine this with a drug-eluting stent. Yeah, distally, as I said, the popliteal artery is open, the posterior tibial artery, also the peroneal. You can see here that the anterior tibial artery has a high offspring from the P2 segment. It's actually open, the first segment, but then actually it's functionally or totally occluded then down at the mid portion. At the foot, you can see here that, yeah, again, the posterior tibial artery is feeding here the forefoot, and I think, or I hope, opening up the SFA will be enough for this patient, and we do not have to, I don't think we have to reconstruct here the anterior tibial artery. Yeah, also we tried, once again, a little bit here now from antegrade to get the wire down, but here we also see that, so the wire goes directly subintimal, and you see this typical loop going here a little bit. It's forming a bigger loop than the artery appears to be distal, so I think it's really subintimal. And if you, I think it's a high risk that if you just push now, that you, dissect here into that so relatively healthy segment distal. So this, of course, you can try a little more with CTO wires, maybe pre-dilate and so on, but relatively high chance that you may just lose time, and therefore we took the occasion here to do here a retrograde approach. Well, what do you think? Maybe, of course, re-entry device would also be an option. However, we thought to puncture retrograde. Yeah, and I think this is, if we go back here, the perfect artery to access here, I personally would say here is the anterotibal artery, which is actually functionally occluded. So if anything happens, nothing can really, there's no clinical sequela. So why puncture the posterior artery? Also, we puncture very far away from the lesion. So therefore, if we puncture here the anterotibal artery, we are relatively close to the lesion, and actually practically nothing can happen. Yeah, let me go further. So that's what we did in that area, as I explained also yesterday in that case. Roadmap we actually only do to really know where we have to take the needle onto the calf, and then we do this with angiography control. I think with ultrasound, the artery is relatively deep here, also relatively small here. So you can see here the 7 centimeter long needle here, and once the contrast has passed the peroneal and the posterior, it appears in the anterior, and then you go in one line with the artery up. And of course, you cannot really see a lot. It's rather feeling when the needle will break here into the artery. And I think it is usually really not so difficult. And then, however, we go oblique because you don't want to somehow dissect now the artery right where the needle hit the artery. If the needle is a little bit too deep, you may dissect, and then the artery may be occluded, or second puncture attempt may be quite difficult. So therefore, we go, once we have back bleeding, left oblique, so we punctured, right oblique, we punctured and left oblique, and then we went back right oblique. And you see this is an 014 wire, not an 018, because I think in these small arteries, 014 is maybe better to take in, and the risk that you dissect is smaller. Well, that's where we are just now. And now we have to take the wire through and hope it's not too difficult. Shouldn't be too difficult here to get through. Yeah, but obviously here it feels like a stiff stump here. So I push the quick cross a little bit in here. I think maybe we could take here a CTO wire, maybe a Victory 30 gram. Yeah, you see with this catheter, doesn't really break in here, always jumps back here, the wire, even if I push the catheter in. Now it jumped in. No, I was just about to take the V8, the Victory, but now it's through. Or broke in, and let's see whether it now can go up into the open segment. But I have the impression, yes, that we broke here into the open segment. Yeah, I think you can never be sure. Let's see. So a safe sign is if I move now this catheter here from antegrade, and if this catheter here moves now the wire tip from retrograde, then they should be in the same position. I think it's pretty sure that we are in a good position here. Yeah, what do you think? Certainly there are different options here now to treat this artery. I think I have to take maybe this wire out once again and give another. Not sure whether we are really. Yeah, so Svenny is arrived, and Svenny is taking now the Judkins really to the arterial wall, but I think I have to give this wire, sorry, it's destroyed, that wire, another angle.
Andreas, what support catheter are you using for your to come retrograde? What's your...
We actually use any of the 018 compatible, nochmal 9 für 18, support catheters. I think it's very helpful to use a short one, so not 150 and also not 135, but only 90 centimeters for the retrograde approach. But I prefer definitely 018 compatible ones compared to 014, because this has the beauty that you really can change from 018 to 014 wires. No, it's. I think maybe we are not. Can you? No, I think this is a good sign. And However, can you twist
Yeah,
the
I
catheter a
tried.
little bit more to the side? So yeah, this one. And let me take in. I couldn't resuscitate here this wire. Now let's take a new one. But from all catheters which are available, I think they're all pretty the same. Rubicon or Quick Cross or Trailblazer. I use something like looks like a Reynolds double curve here to get the wire tip here into the catheter from Retrograde. Just a moment. Sometimes for this step, an O14 is easier. Usually it should be very easy, but sometimes you lose quite some time for this. No. Can you move your catheter a little bit? I think we are still not in this, but we are, yeah. We could, of course, now also pre-dilate a little bit from antegrade. Just a moment. No, not yet, no. Let's pre-dilate from antegrade maybe. No, I cannot really touch here the catheter from...
Oh, that's the other side?
Yeah, let's try once the other side, and yes, please. Okay, here it looks a little different. So once it is at the tip of the catheter, I pull it maybe 0.5 millimeter back and then give it a twist, and then it should be in. Okay, fine. So, yeah, so now I can also push here the support catheter into the catheter, which gives more stability. And the rest can do. Yeah. Once the wire is at the aortic bifurcation, you feel more resistance pushing here at the wire. So Sven is now pulling on the Judkins 5 wrench, and now the wire is out. Okay. And we can take here a 5 millimeter balloon in. Yeah. So now we are going to pre-dilate with the 520 Pacific tester. Yeah, would you have done it differently, maybe with a re-entry device, or choose any other treatment here, atherectomy, or you think it's a reasonable treatment plan here?
I think it's a very reasonable strategy, and even going retrograde for a clot again, you're going into a vessel that's already gone anyhow.
I cannot hear anything.
So I think that this is completely fine, and there's not so much calcium or anything that I think you need atherectomy. But I like this strategy. The antegrade sheath, Andre, is that 5 French or 6 French? And is the tip of it in that disease in the proximal sebae?
Yeah, this is a 6 French, because as I said, we are planning here to take Eluvia stent here into the distal total occlusion. I think we should be through. I'm gonna give here a roadmap before I exchange wire to the antegrade direction. Yeah, so we are through here, and we can, Svenny, maybe you can pull out the wire now. And we can reinsert the wire here now from antegrade down.
Yeah, I do think that the beauty of this was that he went through the anterior tibial artery rather than having to, the posterior tib really being his predominant runoff vessel and critical to perfusion of the foot. Had you compromised that inadvertently, you would have been in trouble. So this was a nice. Now, I don't know, Chris, you use laser? Would the laser have come down, antegrade been a reasonable for that short segment? I mean, it's one of the, it's professed to have its ability to get through some of those segments and stay intraluminal. Would that have been an option?
I use laser to cross from doing a step-by-step technique, not necessarily to try to stay within the lumen. I would rather keep the wire within the lumen, like Andre did, if at all possible. And once you're through the lumen, I use laser if I think there's a real need for it, in-stent restenosis or something like that. I don't think it's necessarily needed here.
So, Andre, your plan is basically to implant a stent into the occlusion and then to treat the entire SFA with DCB, or only focally in the proximal segment?
Well, I thought only in the proximal segment to use DCB, and well, also for distal, we will pre-dilate, and we will pre-dilate with a 5 mm balloon, knowing that this artery is probably not more, will not tolerate maybe more than 5. It looks relatively small. And then, yeah, the plan is to use 5 mm drug-coated balloons proximal, because I expect, due to the fact that it's rather stenotic and not an occlusion, less dissection proximal, maybe less residual stenosis, therefore maybe DCB a good solution. Proximal, of course, could also be a good solution distal, but due to the fact that we also had to go through from both sides, higher risk that we have to take a stent in distally. But of course, we can decide once again after pre-dilation, and then see where we have most of the residual stenosis or dissection.
Well, the background of my question basically is you are using now a balloon which seems to be longer than the former occlusion, and you are touching the vessel wall potentially in a segment which you will later on not cover with a DCB. So you might have some geographical miss where you created a vessel trauma which will not be covered by a drug. So any concern about that?
Yeah. I thought I was precise, but maybe I didn't look precisely. I cannot inject now, but I thought on roadmap that I really took the balloon down to the end of the occlusion, maybe half a centimeter further down. So yeah, it could have stayed a little longer, higher. Is that what you meant?
No,
or?
I thought, well, I did understand correctly that you will treat only the proximal part of the SFA with DCB and leave the mid part untouched, or isn't it?
I understand. No. Yeah, no. Actually, I plan to treat everything with drug-coated balloons down. Yeah.
At what point do you take the wire out of the anterior tibial and hold and get hemostasis? Are they doing that now?
Actually, now. Axel, please. Press. Can you press here? Yeah. Press here.
That's what happens when you let Stan take a lunch break like that with beer.
Yeah. Actually, it's a good point, because I think while the vessel's still occluded, or while it's being occluded with the balloon, is the best time to publish sheath, even when the anticoagulation is still in place. And the fact that this anterior tibial was stuck high is even
can you
more
give me a
important,
roadmap?
because there's no real bony compression there. It's occluded, but still, you don't want to have a pseudoaneurysm to have to deal with.
I agree.
Yeah, so it's a great call.
At the same time, the other thing that I will typically do when I go retrograde is I'll keep that wire in place until I've at least pre-dilated the lesion. Oftentimes, once you get your wire through, you can, if you don't have through access, you're going to have trouble passing a device, atherectomy catheter or a stent. So typically, I'll at the very least, pre-dilate the lesion, make sure I can get devices through the lesion before I lose that through access, which is what he did here.
Okay, so we pre-dilated, maybe not too long. Is this something which you would do longer here? Or does it matter how long we stay open with the pre-dilation balloon here? Okay, kannst du den Draht hier rausziehen? Yeah, so now I take this here, Axel, okay. Let me go down here so that we do not lose wire position here. Once we take the balloon out, das ist ganz trocken, ich muss mal aufpassen. Okay, in a second we can have here an angio, and then we can decide once again, what to do.
Kannst du mal das ein bisschen enger machen und die Brille draufsetzen? Sonst beschlägt die immer. Brille auf, System drauf.
Ja.
Ja, danke. Nur für den Fall, dass ich noch.
Yeah, sure. Clearly, it would be a little safer to keep the wire or distal access a little longer in, but let's see. Well, I can imagine also proximal in eluvia stent would be a good option.
Yeah.
Then we see a little bit of residual stenosis maybe. Just a moment. Let's first do the full angiography, also have a check of the anterotibial artery, and then maybe decide once again. That's interesting that actually distal looks better.
So, well, you have to change your strategy, put in a stent proximally. And,
I think so, yes.
You said Eluvian
Yeah.
Ranger.
Okay, still a little bit of bleeding, so Axel, please. Yeah.
Hier nicht schön drücken.
Yeah. Okay, let's see the pictures. Yeah, I think so. I mean, even if we do now more prolonged ballooning, I also saw some residual stenosis, or the balloon was not fully open when I inflated it up to 12 atmospheres. So I think a stent will be here a good option. And however, thereafter, I can imagine that drug-coated balloon treatment actually can be enough. We think we should do another angulation, of course, but I personally think we can actually start with a stent proximal and then see how it looks like, and then go further down with drug-coated balloons. Okay? So let's take here the eluvia. We take here, that can be a long stent, 6, what do we have? Can be, we can take 650, 620. That actually is not really a big difference. 620, please. Yeah. Yeah, of course, from now on, it's a relatively regular case. I find it sometimes hard to distinguish between severe dissection and residual stenosis. I can imagine that maybe if we do more of these complex SFA lesions with drug-coated balloons, that we also may sometimes measure pressure gradient to help us in our decision.
Andre, for the puncture site that still had some extravasation, what's your strategy for controlling that? The anterior compartment is the most susceptible to compartment syndrome. So do you tend to find that a higher
You shouldn't let it. Yeah, absolutely sure. It cannot bleed when you take the patient from the table. That's absolutely crucial, that there's no bleeding seen at the end, but usually it is absolutely easy to solve this without any further means. We just compress with our fingers. Usually really 5 minutes is enough. We gave here a little bit more heparin here, 7,500, so it could take a little longer. But we don't need to take a balloon in or blood pressure cuff from outside, maybe, but not with a sheathless approach. Okay, Svenny, can you implant the stent while I continue here to press here on the anterotibial artery? I think we can take here the first collateral, like this here.
You know, maybe some of the panel can comment about, we all have these cases where we have dissections and so on. And in the past, where we didn't have the kind of stent technology that we currently have, we often had to go back with prolonged inflations, and we would check pressures, and frequently on follow-up, those patients healed. Those dissection planes healed if they were not particularly obstructive. So, I mean, at what point do you immediately go to a stent? And at what point do you go back with a more prolonged inflation and perhaps a different strategy? Do you have a length criteria? Do you have what sort of, please feel free to comment on perhaps what you do in your own practices.
I think with a pretty deep dissection like that, and the technology we have today with a precisely deliverable drug-eluting stent here, I think it's pretty easy to do a good, durable, predictable result. That's what I would say.
I think to some degree it depends on your tolerance for stents and what other means you use. Some forms of atherectomy are fairly good at taking out those dissection planes and resolving some of the dissections. Certainly no harm in a low-pressure balloon inflation for a few minutes, and that's a good option. But now we do have some good stent technology that has lowered the bar for stenting, lowered the threshold for stenting for a lot of us, and that's a helpful thing to have now.
Yeah, I think this osteal SFA section is particularly prone to restenosis. In the era before antiproliferative therapies, it was one that I insisted on stenting every time when there was lesion there. It's changed a bit with DCB, but I agree that the availability of high-quality drug-elution stents has changed it's kind of brought me back full circle to stenting those osteotomies.
Okay, this doesn't mean we are finished with the case. They just lost wire position, shouldn't be a problem. So, yeah, I also don't know what your times table says. We can give you an angio, because the rest will be here. Yeah, that went luckily nicely in. So I give you a shot here at the SFA proximal. So that looks nice here. And we continue now with drug-coated balloon treatment here. This portion. Sorry. Actually, I will go now from proximal down. And yeah, this will of course take some time here now. We may have the occasion to come back and show you the result, but otherwise I think we are already quite happy with this case.
Yeah, so Andre, I think what we'll do is we're going to go on to a break here now, and then when we come back, we'll come back with you and check and see if we can't get a final picture and see how things worked out, all right? Thank you. Very nice case. Thank you very much.
Perfect. Yeah, thank you.